The following podcast is part of a certified educational activity titled Putting the Puzzle Together in Advanced Ovarian and Cervical Cancers, Translating Evidence into Practice for Approved and Emerging ADCs. Access the entire activity and complete the post-test at peerview.com/WMS860. Downloadable slides and practice aids are also available.
Hello, my name is Dr. Wagner. I'm medical oncology from Vall-d'Hebron Institute of Oncology in Barcelona, Spain, heading the gynecological cancer unit for this institution. Welcome all to this educational activity entitled Putting the Puzzle Together in Advanced Ovarian and Cervical Cancer, Translating Evidence into Practice for Approved and Emerging Antibody-Drug Conjugate. I'm very pleased to be joined by my esteemed colleagues, Professor Susanna Banerjee, a medical oncology from the Royal Marsdens in London.
Thank you, Dr. Wagner. It's really good to be here today with you. I'm really looking forward to discussing the use of antibody-drug conjugates and looking together at what this means for our patients with ovarian and cervical cancer and sharing our perspectives on how we integrate these drugs in the clinic.
Wonderful. So let's get started. I think it's quite important to set up the foundation where we do stand with the therapy for advanced ovarian cancer and cervical cancer. So in advanced ovarian cancer, most of our patients are diagnosed with a stage 3 or 4 Theo classification. And although the majority of them respond to first-line therapy based on platinum chemotherapy plus surgery, the majority of them will relapse within 3 years after the first therapy. And this is our main, I would say, main unmet need to try to reduce the recurrent rates. Otherwise, we will still facing an overall response rate less than 50% in 5 years. Something very similar happens with cervical cancer. When the patients are diagnosed in early stage, the rate of cure is quite high. However, for those patients diagnosed with advanced or recurrent metastatic cervical cancer, the rate of cure is quite low. We can say that less than 20% within 5 years. So how can we improve this figure? I must say that the best therapy that we have on the horizon are the ADC. I must say that ADC is the new kind of personalized therapy in the gynecological tumor. However, I'm very interested. We have carried out and survey within Europe, and then we have learned very important topics. We have learned that many of the oncology, they don't feel comfortable in terms of managing the side effect associated to ADC. And secondly, they don't know how to sequence ADC with chemotherapy. They don't know what is the best timing to treat our patient with ADC. And honestly, they don't know how to implement all the data that we have from the ADC in the gynecological tumor and in particular in ovarian and cervical cancer. So taking into account this outcome, the goal for today in this educational activity is to try to teach our colleagues to combine the information that we have on ADC in ovarian and cervical cancer. So we will review the literature that we have so far, but on top of that, we will review a few clinical cases, indeed 2 clinical cases, one advanced ovarian cancer for Mary, one patient who relapsed after a first-line therapy as platinum resistant, and one for Sophia, a patient diagnosed with recurrent cervical cancer. So when we review the cases, you should think about it. We should need a biomarker to guide the therapy, what treatment options are available for those patients, and what patients' preferences need to be considered for the next step. So, Dr. Barnagy, over to you.
Thank you. Thanks very much. So we're going to start with the current treatments that are approved in terms of ADCs across gynecological cancers. And as Dr. Oakland's explained, this has been a really exciting progress where we are seeing in clinical trials and also in real-world practice improvements in terms of overall survival, response rate, and progression-free survival. So the first drug I want to mention is mirvetuximab soravtansine. Now, this is an ADC that targets the folate receptor, and the payload, which is the cytotoxic or chemotherapy aspect of the ADC, is called DM4, which is a tubulin inhibitor. And there's regulatory approval in terms of FDA and EMA in 2024. Tisotumab vedotin is an ADC that targets tissue factor, and that's an MMAE-based payload. And this is approved in cervical cancer, FDA approval in 2024, in EMA approval in 2025, and also approvals in Japan and Hong Kong. And then finally, there's trastuzumab deruxtecan, TDXD, which is an ADC that targets HER2. And this payload is a topoisomerase 1 inhibitor, so not a tubulin inhibitor like the others. And this received FDA approval based on the Destiny pan-tumor early phase clinical trial in IHC 3+ HER2 positive tumor agnostic indication with relevance in gynecological cancers to cervical, endometrial, and ovarian. So this approval was in 2024, and there are approvals under review in Europe and Japan, and also MHRA approval is in place in the UK. There are other targets of interest that we can discuss in gynecological cancers, and there's a lot more to study, which we will discuss across the gynecological cancers in terms of ADCs. So I'll now move on to focusing on the folate receptor as a target. And the first tumor for this to be tested in terms of an ADC and then approved has been ovarian cancer. The folate receptor is a protein, it's a membrane protein, and it's highly expressed in ovarian cancer tumors, in particular high-grade serous ovarian cancer. Now, the level of expression can vary within subtypes and also within high-grade serous ovarian cancer. And we've learned a lot through clinical trials over the years. And the actual staining and the scoring is really important and guide treatment decisions, as we will talk about. So the Mirasol study was a phase 3 global study, randomized controlled study in platinum-resistant ovarian cancer in patients that had folate receptor high, that's more than 75% folate receptor high platinum-resistant ovarian cancer. It was 1 to 3 prior lines of therapy. And here are the practice-changing results. The primary endpoint was met with an improvement in progression-free survival with a hazard ratio of 0.65, so a 35% improvement with mirvetuximab compared to standard of care chemotherapy, which was weekly Taxol, topotecan, or pegylated liposomal doxorubicin. What was really notable was that there was an improvement in overall survival. So the hazard ratio was 0.67, a 33% improvement in overall survival, which translated to a median overall survival of around 12 months to over 16 months. And we hadn't seen this at that point when this was released in platinum-resistant ovarian cancer. Importantly, when our patients have a heavy burden of disease, potentially going into bowel obstruction, the response rate was significantly higher compared to our standard of care chemotherapy. And this was 42% versus 16%. So alongside efficacy, and as Dr. Acknin highlighted earlier in this introduction, toxicities are really important And in terms of ADCs, as I've mentioned, they are cytotoxic chemotherapy, but a targeted way of delivery. And we're learning a lot more about the mechanisms of toxicities. What's new and what we haven't seen in terms of the gynecological cancers practice till ADCs is ocular toxicities. Now, ocular toxicities for the majority of patients were of the lower grade. So 3+ again is in dark blue. But as you can see, around 50% or so would have some degree of ocular toxicity, most commonly blurred vision. But there's also can be keratopathy and also dry eyes. And therefore, mitigation strategies, counseling patients is really important. Eye drops, for example, avoiding contact lenses, and certainly having ophthalmology assessments. So what about other ADCs targeting the folate receptor? We've talked about mirvetuximab. There are other drugs in development and looking very promising. And one of those drugs is Rina-S. The payload here is exatecan. That's a camptothecin-derived topoisomerase 1 inhibitor. So different to mirvetuximab, as I mentioned, it targets tubulin. So the relevance of different payloads may well affect efficacy, but also toxicities, and also our decisions of how we treat patients in terms of sequencing, as well as combinations. This is an example of a phase 1/2 study called Rainfall, where Rina-S showed some early signals of efficacy in advanced ovarian cancer, with response rates of between 45 and 55%, and waterfall plots indicating that the majority of women had some degree of shrinkage with this ADC. So responses were seen regardless of folate receptor expression. And this may be really very relevant in increasing the number of patients that may be eligible for an FR-directed therapy. In terms of tolerability, side effects were mainly hematological. So far, there's been no major signals for eye toxicity, neuropathy, or interstitial lung disease. Okay, and you can see that GCSF use was prevalent there, over 30%, in order to maintain treatment with regards to myelosuppression. So a phase 3 study called Rainfall 2 is planned and ongoing in platinum-resistant ovarian cancer, as you can see here, a randomized trial against standard of care chemotherapy options. People who have had mirvetuximab prior treatment is permitted if patients had positive FR expression. So another very promising folate receptor ADC is AZT5335 or torvuta-s, which it also has a topoisomerase 1 inhibitor payload. And this study was presented by our co-chair here, Dr. Aknin, at ESMO, and this is the Fontana study. And I'm very pleased to be an investigator also in this study. What we see here in this waterfall plot is response rates across doses of 50% or more, and very encouraging in terms of safety profile as well. So I'm very excited, alongside other FR-directed ADCs, about these drugs going forward in other types of ovarian cancer, platinum-resistant ovarian cancer, platinum-sensitive potentially, and also combinations. I'm now going to move on to HER2 and gynecological cancers. Trastuzumab deruxtecan, 2DXD, you'll be familiar with in other cancers such as breast cancer. This payload, again, is a topoisomerase 1 inhibitor. It has a high drug-antibody ratio. I haven't mentioned that for the other drugs so far, but it's relevant in terms of toxicities and also efficacy. What we see here is the results in terms of the Destiny Pan-Tumor study, which is a phase 2 study across tumor types, but included endometrial, cervical, and ovarian cancer cohorts for patients that had HER2 IHC3 or 2+. And testing could be local or central. Local testing was around 75%. And prior HER2 therapy was allowed. What you see here, although relatively small numbers, is a very encouraging response rate, both in cervical cancer and ovarian cancer, which we're not used to seeing in this setting. So in ovarian cancer, across the IHC scores, 45%, and in cervical cancer, 50%. With IHC3+, the response rates appear to be higher, 75% in cervical cancer, 63% in ovarian cancer. And what we see is the median progression-free and overall survival that was presented at ESMO also being very encouraging in this small cohort, but certainly a very targeted biomarker-specific approach that may help women with these diseases that are difficult to treat. So again, toxicities which are notable, in particular with TDXD, I want to highlight pneumonitis or interstitial lung disease. And this has also been seen in other tumor types. So any grade ILD was about 10%. There were grade 5, so deaths related to interstitial lung disease. Drug-related deaths was around 2% or so, 1.7 overall in the gynecological cohort. But drug discontinuations due to treatment-emergent adverse events was relatively low, around 5%. Again, myelosuppression, nausea, fatigue in terms of grade 3 events are something that we need to work with in terms of supporting our patients. And with pneumonitis, I'm sure we'll discuss it. It's really important to actively look for this and treat early. So I'm now going to talk about one of the patient cases and just introduce the case again. And Dr. Alcalin and I will discuss some of the possibilities. So we have a 64-year-old lady who has recurrent platinum-resistant ovarian cancer, who's been referred for potential treatment options. Patient had previously had carboplatin, paclitaxel, and bevacizumab. There was hypertension related to bevacizumab, and she subsequently, as a next line of treatment for platinum-resistant ovarian cancer, was treated with pegylated liposomal doxorubicin. The FR alpha is high, TROP2 is present, and the HER2 IHC was also done, and it was 1+. And the patient's tumor was HRD negative, and she did not receive a PARP inhibitor. So some of the questions really are regarding, well, she appears to be eligible in terms of number of prior lines and folate receptor high with platinum-resistant ovarian cancer, eligible for mirvetuximab. So the question is, Dr. Wackden, one of the questions we can start with is, would you treat with mirvetuximab, or would you think of another chemotherapy, a non-ADC, or potentially another ADC?
Honestly, this patient having a tumor with high folate receptor alpha expression, I don't have any doubt that the first option will be mirvetuximab. The better, the sooner.
I agree. And I'd certainly, given phase 3 level evidence of an overall survival improvement, I'd like to use most active agents that are proven earlier, because we can't predict the future for how well our patients will be subsequently. Hand in hand, adverse events, Dr. Wackden, occurs, and some questions are related. If a patient has adverse events with an ADC, what happens next? Can she have another ADC?
Yeah, I mean, you have already, explained. I mean, the point when we are sequencing ADC is the payload that the ADCs contain. And mirvetuximab has a microtubule inhibitor payload, and the other ADC that we have on the horizon, they have a topo-1 inhibitor as payload. So having mirvetuximab as first ADC on our patient journey therapy doesn't prevent the patient from receiving subsequent ADC when we will get the approval. I think this is the key point that we should keep in mind when we are thinking of sequencing ADC. We need to determine what is the payload that this ADC contains, and then determine how we can use all of them.
Thank you. And what if this patient was FR alpha low?
Yeah, this is the key point. Honestly, if they were a folate receptor alpha low, I will try to look for a clinical trial with ADC that are enrolling patients regardless of folate receptor alpha expression, because honestly, for me right now, the most promising agent that we have on the horizon are the ADC. We don't have any ADC approved yet for folate receptor alpha low, but we have a bunch of clinical trials that are enrolling this patient, and they will be my first option.
I completely agree with you. And one of the questions that always comes up is, how do we introduce the topics of clinical trial enrollment, I think certainly in my practice, I hand in hand speak about the standard of care option, which in this case would be the chemotherapy agents that we've talked about, and counseling patients appropriately about what an early phase clinical trial means, as well as the later phase, depending on which phase is open in a trial at that time. So, and that includes explaining the intensity of the trials and safety checks. But, I completely agree with you. The ADCs are looking very promising, as we've seen and shown today. And I'd very much, for an individual patient, like the opportunity to enroll into a clinical trial if it's suitable.
Absolutely. Absolutely. Absolutely.
So one of the questions we've talked a bit about, quite a bit about ovarian cancer. But, what about ADCs and cervical cancer? I know I showed a little bit about the Destiny pan-tumor outcomes. We saw that TDXD might be an option, for HER2 expressing. But there may be others, and there may be a different approach of how we go forward. So I'd really like you to walk us through the data.
More than happy, more than happy. I mean, indeed, in cervical cancer, recurrent metastatic cervical cancer, we have had a turning point in our therapeutic approach with the arrival of tisotumab vedotin. Tisotumab vedotin is an ADC that is targeting the tissue factor. The tissue factor is the antigens. As you know, tissue factor is a transmembrane receptor that is highly expressed in both squamous and adenocarcinoma of the cervix. And the normal condition, tissue factor is involved in the coagulation cascade. However, under oncogenic condition, tissue factor is involved in tumor angiogenesis, proliferation, and thrombosis. So, tisotumab vedotin is an ADC. The payload is a microtubule inhibitor. It's called monomethyl auristatin E, MMAE, and is targeting the tissue factor. What have we learned of tisotumab vedotin in cervical cancer? We have a very important trial that is called innovaTV 301. In this phase 3 randomized clinical trial, we enroll patients with recurrent or metastatic disease. Those patients must have received prior platinum chemotherapy, and they could receive immunotherapy or not. It was not an inclusion criteria that the patient must have received prior immunotherapy. This is something very important that we should keep in mind. All patients must have measurable disease. Then the patients were randomized in a 1-to-1 fashion to physician choice chemotherapy. Weekly paclitaxel, topotecan, irinotecan, pemetrexed, depends on the region, or the experimental drug at that time that it was tisotumab vedotin. The dose of tisotumab vedotin was 2 milligrams per kilogram every 3 weeks. Very important, the primary endpoint, overall survival. Why? Because in the recurrent metastatic cervical cancer, our goal is to improve our patient survival. And then very important stratification factor. For sure, performance status is a very prognostic factor in cervical cancer, the use or not of immunotherapy, and then the geographic region. And then we have also key secondary endpoint as investigator PFS and overall response rate. And then I'm very glad, to inform that the trial was positive. The trial reached its primary endpoint. Tisotumab vedotin improved overall survival compared with physician choice chemotherapy with a hazard ratio 0.7. It means tisotumab vedotin reduced the risk of death in a 30% compared with chemotherapy. And when we look at the median overall survival, it was 11.5 for tisotumab vedotin, 9.5 months for chemotherapy. And the key secondary endpoint, PFS, was also superior for those patients who received tisotumab vedotin, with a hazard ratio 0.67. When we look at the median, it was 4.2 months for the tisotumab vedotin arm compared with 2.9 for chemotherapy. So in summary, tisotumab vedotin shows superiority in primary and key secondary endpoint compared with chemotherapy. And when we look at the overall response rate, that we cannot forget that it's an important factor in terms of improving the quality of the patient because we reduce the tumor size. The response rate was 70.8 for TB compared with 5% for chemotherapy. And indeed, a few patients, they were able to achieve a complete response with TB. This percentage was less than 3%, but there's no one in the chemotherapy arm able to achieve this complete response. And the key question that we have with ADC, as you have mentioned previously, safety, the toxicity profile of TB. I mean, I must say that TB have three very characteristic side effects. One of them, ocular events. The second, peripheral neuropathy. And three, the bleeding event. So when we think about the grade of these adverse events, the grade 3 or greater indeed were quite low, only 4% for ocular event, 5.6% for peripheral neuropathy, and less than 3% for bleeding event. And the most important, there was not grade 5 related with the drug. And then the most important point is that there's no a deterioration of quality of life when the patient receives TB. Indeed, the quality of life is maintained with this regimen in our patient with recurrent metastatic cervical cancer. So one of the things that we should learn before treating our patient with TB is how to manage ocular events. I mean, we have been working on that for a long time, and now we have a practical tips, practical guideline that clinical nurses, physicians, and for sure patients should be aware of that. So the main symptoms that the patient may suffer from the teplizumab vedotin in terms of ocular events are conjunctivitis, keratitis, and dry eye. How can we prevent, how can we mitigate these ocular events? This is very well established and start before receiving the drug. The patient will receive at the day care something that we call vasoconstrictor eye drop, and then the patient will receive a kind of ice pack on eyes during the infusion. And later on, when the patients go home, they should receive corticosteroids eye drop during 3 days after the dosing, every 3 every 3 hours, no, every 8 hours, 3 times per day. And they should use lubricating eye drop during all the time that they precise. But despite having all these measures, if the patients start suffering from any kind of ocular event, they should contact with the medical team, with the clinical nurses, and then we should schedule a visit with the ophthalmologist in order, to determine what's going on, if we can improve this kind of symptom that the patient have. Another important point is the peripheral neuropathy. So we should make a specific question to our patients in order to identify if they are suffering from peripheral neuropathy. These questions are related with the joint pain, muscle ache, if they are having any issue with the balance. Another point is that maybe sometimes the patient, they want to hide the symptoms because they want to continue on their therapy. So they should look at them, and then we try to recognize if they have this kind of issue walking when they are, getting into our office. And another point is about the bleeding. We have seen that bleeding is another adverse event. So we should ask about the nose bleeding and, mouth bleeding in order to determine if they are suffering this kind of adverse event. So in summary, we have a new therapeutic approach for our patient with recurrent metastatic cervical cancer, that is tislelizumab vedotin. And now let's discuss all together my patient case. I mean, she's a lovely 52-year-old. I mean, she was diagnosed with 4B squamous cell carcinoma of the cervix associated to HPV infection. She was treated with first-line therapy based on carboplatin, paclitaxel, bevacizumab. She achieved a partial response. 5 months later, she had progression in the lungs and the para-aortic lymph node. When we look at her tumor testing, we learned that the tumor was PD-L1 positive, HER2 negative, and from the point of view of the general status, she had a COG1, the blood pressure was under control, and there's no abnormality in the renal or liver function. So, taking into account all of this, we make the selection, but there's something that we should point out regarding her underlying condition. She was suffering from ulcerative colitis, and I think this is a key point that we will discuss in order to determine the therapeutics. So, how can we treat our patients after progression on platinum failure? Should we have any kind of particular baseline test before starting the therapy? How can you explain the option to our patient, Dr. Banerjee? So, what will be your first option for this patient?
Well, I think, if everything's available to me, which I appreciate access varies across the world, I think one of the options to consider would be tisotumab, in terms of based on the phase 3 positive data that you've just gone through. Other aspects of options include consideration, although, as you pointed out, part of her history, but consideration of an immune checkpoint inhibitor. But she has a history of ulcerative colitis, and if that's active and she's on treatment, then that's clearly going to be an issue in terms of immunotherapy toxicity. So it's also about optimizing and working out the history of immune-related comorbidities. Also, as in the clinical trials, standard of care, which is not great, chemotherapy is an option, but I'd very much like to use the preferred options that I've just listed. And of course, like our earlier discussion, we're in a situation where, fortunately, there are clinical trials for women with recurrent cervical cancer looking at ADCs. And if a patient is potentially eligible in the context of a clinical trial, then I'd also be considering this.
Yeah, this is very important. So I think the main discussion that we have with our patients right now is for those patients who have not received immunotherapy and they don't have any kind of underlying condition that prevents them from using immunocheckpoint inhibitors. How can we select between cemiplimab, that is the immunotherapy that we have available in Europe and Japan, and tisotumab vedotin? So I think this is a long discussion that we have with our patient. And I think one of the main points is how quick the patient can get a response with TB compared with immunotherapy, that it takes more time, to provide the response to our patients. So, but honestly, in this particular case, a patient suffering, as you have very nicely said, a colitis, I don't have any doubt that I will go for tisotumab vedotin. And honestly, we can also treat later on if the patients are under control with immunotherapy. But as we mentioned with mirvetuximab, we cannot forget that the TB has improved overall survival, and this is, the key point for our patient with recurrent and metastatic cervical cancer. So thank you so much, for having this discussion with me. So, how can we say? We can say now that we have a bunch of ADC on the horizon targeting different antigens. We have ADC targeting TROP2. We have more ADC targeting folate receptor, cadherin 6. NaPi2b, Nectin-4, Claudin-6. I mean, this is a long list, B7H4 that we have a new ADC. So I think that probably within 2 or 3 years, this educational event, it will last more than 1 hour if we want to review the data from all ADC. But I mean, the good point, the bottom line is that we have a lot of hope for our patients on the horizon.
Thank you. I've really enjoyed this discussion. I agree with you that the field is evolving fast, and there'll be a lot of exciting, hopefully positive data to go through. So we've seen the evidence that supports the use of ADCs currently for treating patients with ovarian cancer and also cervical cancer. And we've learned some of the effective approaches for how to integrate this in terms of practicalities of efficacy and also side effects to support our patients.
It has been a real pleasure, sharing this activity with you, Dr. Banerjee. Always pleasure. And thank you all for joining us today. I would like to remind you to download the practice aid associated with this educational activity as a resource for you, your staff, and your patients. Thank you once again, and I will hope that you have found this activity informative and useful for your practice. Thank you so much for your attention.
Thank you.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education, and by the European Board for Accreditation of Continuing Education for Health Professionals. This activity is supported by an independent educational grant from Genmab. To access all materials for this activity, visit peerview.com/WMS860.